The Gauteng Health Department says 6 members of the COVID-19 war room have tested positive for coronavirus. The department says all those affected are doing well and are self-isolating at home. This is just it's just as the number of COVID-19 cases in the province continue to grow. Gauteng is now the epicenter of COVID-19, yet again having overtaken the numbers in the Western Cape. What does it mean for the province, and what are the dynamics that have contributed to this rising number of infections? We're joined by Professor Adrian Jordaan Puren from the National Institute for Communicable Diseases. Good evening, and thank you so much for your time on News at Prime tonight. Firstly, when you look at the scale of work that you are having to do, we know how much preparations the NICD has put into this moment. Has it been better or worse than what you had anticipated?
No, I think that the NICD has been involved as part of a consortium, in fact, to do modelling exercises to determine what our capacity requirements are. And so I think the events that we are currently seeing has certainly been modelled. So, for example, I think there are about 75,000 cases that have actually been tested positive for COVID, and that's keeping within our model parameters. Similarly, with the numbers of deaths that we are currently observing, certainly, again, it fits within those models. So these numbers are not exactly unexpected from that perspective, and in terms of the readiness that is required for us to manage this particular outbreak in Gauteng specifically.
The big questions now come down to capacity of the healthcare system in terms of hospitals, but even capacities of your own institution and how quickly you're able to do some of the work that you have been contributing to in terms of the fight against COVID-19. Let's speak about the issue of testing firstly. Where are we with that? Have we been able to deal with some of the backlogs that we've been experiencing?
So my understanding is, at least for the country, I know that the Western Cape has certainly taken care of its particular backlogs. I understand that the other provinces are certainly, or the other NHS laboratories are still working on their ability to remove or reduce their backlogs. So you can still see that from the actual time to result, for example, it still varies based on where you are. So Gauteng, I think, and the Eastern Cape still have the longest in terms of their turnaround time. So that is really critical for us to try and reduce that. I think the other problem that is faced is that, in fact, we've reduced the number of tests that is currently being done, and I think that may well be ascribed to the fact that there may well be the lack of reagents that may well be affecting the actual testing. I think the other critical thing that I want to mention as well, because I know the Western Cape has specifically changed its particular policy around who to test. So I think when we look at the numbers, I think we need to be cautious as to who is actually being tested under these circumstances. I know that, at least in the Western Cape, they've been very clear that they are focusing on, for example, healthcare workers and those that present with specific conditions to the actual hospitals or clinics to be tested. I would assume that similar policies are probably being applied by the other provinces, and specifically here in Gauteng as we see the actual numbers increase.
So what does that mean then for the numbers that are being recorded on the day-to-day and the actual rate of infection that exists in the country?
Yeah, so I think it becomes a bit more complicated in terms of the types of analysis that we can certainly do. So we probably will have to triangulate that data with, for example, the data on deaths, for example, to really give us a sense of whether or not, if we're looking for a decline in the numbers of infected individuals, we may certainly look at the lab data, but we will probably be looking at, for example, declines in death, for example. So we've not reached the peak based on the current data that we have, so we may still well be way off in terms of the peak. It may be July or August, for example, that we'll reach the peak, and then we'll slowly see a decline in the numbers of cases, and then that should be accompanied by a slower decline in the numbers of deaths that we are currently seeing. So we'll certainly look at the deaths that are being recorded as part of the statistics that you see on the various dashboards, but I think the MRC's work on terms of monitoring what we call the excess mortality will then even become even more critical for us to have a look at in terms of what's actually happening in the country.
What becomes the risk associated with the lack of perhaps more definite numbers when it comes to tracking COVID-19, especially for the subsequent actions that are supposed to follow once one has been tested positive, like the tracking and tracing and some of the follow-up that comes out of that positive result?
Absolutely. So again, this is the responsibility around the tracking and tracing does not reside at the NICD. That's more of a provincial level function, as I understand it. I have been trying to locate some of the numbers, and I know that Gauteng, for example, has, when I've noted the reports, are certainly releasing the actual cumulative numbers, if I get that right, in terms of those individuals that they've actually put in self-isolation or quarantine or isolation, and in fact also the numbers that they've de-isolated. But I think those, you're quite right, will be really critical again to give us a sense of what the progress is around those particular activities. I think there is also, as you know, various efforts that includes the NICD to have some level of surveillance around sentinel hospitals to really give us a sense of whether or not capacity has actually been met. It includes all the private hospitals at this particular moment, as well as a proportion of the public health sector hospitals. I think we should be encouraging more and more of these particular hospitals to really participate, to come back to your point about whether or not our capacities are being exceeded, because I think we certainly are seeing reports of hospitals exceeding their capacity, but it'd be useful to actually have the data, because that data is really critical. If you recall, when we have lockdown level 5, the idea was to shift the curve and lift the line. To shift the curve was for us to lift the line in terms of our preparations, to ensure that we had the necessary hospital capacity in terms of the numbers of beds, non-ICU beds and ICU beds, as well as access to oxygen. So those are the critical things that need to have achieved as we face this particular surge in cases.
What would you say are some of the biggest challenges that you are facing at the NICD when it comes to your own response to COVID-19?
Well, the NICD has a specific role, and its role is really about describing the epidemic and working with various individuals and organizations to really give us a good sense around what's actually happening. So I think it's really about having good data, analyzing that data, the necessary collaborations with various organizations that are critical within the provinces and at national level to really get a good sense about the nature of this particular epidemic and how we can actually contribute to the management of this particular epidemic. As you know, the NICD has also been involved in various of the policy decisions, the various guidelines. So keeping up to date with the literature, keeping up to date with what's actually happening outside, certainly informs the NICD's decisions.
We've seen different capacity coming in from the provinces. So some provinces, like your Eastern Cape, have been overwhelmed. We've talked about the testing backlog in the Western Cape, and undoubtedly more of Gauteng's own challenges will be made clear as the days go by. And I wonder then, what does this do for the quality and the credibility of data that's coming through to the NICD? Are you finding that there has been a same standard of reporting, or are you struggling with information from different parts of the country, depending on what the administration in those provinces is like?
Yes, I'm not directly involved in that, so I can't answer that directly, but you're quite right. I think it will be really important to have data that is credible and that is actually useful. I think there are tools whereby one can certainly try and mitigate those risks with regard to the quality of the data and be able to actually model that data to give you a sense of actually what the trajectory is with regard to the epidemic. So I think there are efforts, there are mathematical tools, for example, or models that one can certainly try, given the types of challenges that you've certainly highlighted.
Sure.
And of course, especially with the changing testing strategies, because those tests will really be done at a specific level. And we know that there's a large amount of asymptomatic transmission. We know that there's a large number of people who are infected but don't necessarily present to hospitals. So I think we need to make certain assumptions around that to actually form our particular models that we will actually then present.
We're often told about the frontline workers, those who are directly in the hospitals, and it's not very often that we get to speak to individuals like yourselves who are working just as hard, but in a different capacity, such as the National Institute for Communicable Diseases. Perhaps just maybe slightly on a personal level, when you compare this moment to what it was before COVID-19, how would you say that how the system functions, or even the kind of work that you've been doing, how has that been impacted? How different is it?
So I'm here really as a spokesperson around that, so I'm not always directly involved. I'm involved in some aspects around the COVID outbreak. But I think certainly with my interactions with the various levels of staff, it's certainly changed our world in terms of the way in which we work and approach our work. It also means that our interactions with various organizations become really key in terms of trying to present a coherent picture, a current way in which we could certainly manage this particular outbreak. So I think the one thing I do want to emphasize again is that when we look at that data, we know that several people are infected and will recover. But I think we also need to emphasize, coming back to your point about that capacity, are the outcomes, the poor outcomes that can result from this. And specifically, I think in individuals who have comorbidities such as hypertension, cardiac disease, any lung infections, for example, any other immune disorders or dysfunctions in diabetes in particular, these certainly contribute to poorer outcomes. And old age, or age about 60, for example, those are the characteristics. And so when we look at that data, at our world of change, we really are looking at a group of individuals are really at high risk. So even though the majority of people will recover because they're in the younger age groups are healthy, but we really want to focus on those specific subgroups that will end up in our high care centers, in our ICUs, and will have a poor outcome. So I think it's changed our world. We think that we're youthful, we'll survive, but in fact our focus needs to be on those particular individuals.
Oh, of course, the staff members of the NICD are not exempt from the society, so they too are at almost the same level of risk as everybody else. And I wonder, how are you dealing with that in terms of outbreaks, perhaps in your own institution, and the kind of impact that can have overall in the service that you're providing during this time?
Yeah, so the NICD is part of the broader National Health Laboratory Service. So yes, I think we're cognizant and are very sensitive to the fact that we do have staff that have become infected, and because that's as a result of the high community transmission that we are currently seeing. So I think there are efforts to what I call to work in safe bubbles, to try and make sure that there's redundancy, to make sure that those key things that I think are the only elements that we have available to us to prevent transmission, and that is the physical distancing, the hand hygiene, the wearing of masks, the cleaning of surfaces. Those are all the key things that we try to emphasize, not only in our labs, but to our staff when they are traveling as well, to ensure that they protect themselves as much as possible. And so, but it's very difficult, as you know. Wearing a mask has a certain level of protection, but it's not necessarily foolproof if you're in a taxi commute, for example, where this taxi commute is filled with 10 to 12 people, where there's no physical distancing, for example, and people are not wearing their masks or not wearing them correctly. So our staff are at risk, and we do try and ensure that they are protected as much as possible, whether in their commute or when they are at work. But inevitably, you're right, we do see those events happening.
All right.